Okay, all right. Well, let's go ahead and get started. Good morning, good afternoon, good evening to everybody who's joining us today. Thank you so much for tuning in for our second week of our Ortho-Pediatrics and Oncology conference series. Today, the focus will be on chronic osteomyelitis. I want to really, first of all, before we get started, thank Dr. Amanda McCoy and Dr. Ramiz Kudzi for contributing to excellent lectures, which are available online for free on our YouTube page. They're available in Spanish and French as well. Fantastic lectures. Highly encourage you all to take a look at those. And today we'll be focusing on case-based discussions. So we have some really excellent case-based discussions, and Abdullah will be moderating the session today. So I'm Kieran. I'm the course chair and director of HGOC. Just wanted to welcome you all today and hand it over to Abdullah. Abdullah, go ahead.
Awesome. Thank you for the warm introduction, Kieran. Hello, everyone. My name is Abdullah Njai. I'm a second-year orthopedic surgery resident at the University of Missouri here in the United States. I'm looking forward to hosting this second session of our series. I heard last week was entirely very fruitful, and I'm looking forward to kind of keep these discussions going. So as for the format, and I'll just slide. Give me 1 second. Looks like we may have lost our slides.
Emily, you mind pulling them up?
Yeah, I can share. Okay.
Perfect. Thanks, Emily. So as I was briefly saying, I'm Abdullah Njai. I'll be our moderator for the day. As for the course agenda, so this is the second series of our course. So last week we had the opportunity to go through limb deformity. This week we'll be focusing on chronic osteomyelitis. And then next week will be our closing session, which will be on primary bone tumors. Just a brief introduction on using Zoom. I think you all are all pretty familiar with it as of right now. But we do have the opportunity to kind of use the show captions features. This will be a way to kind of select languages for translations as we go through the session, given that we want this to be a global course as well. Since we do have so many participants, just encouraging you all to use the raise your hand feature as we go through if you have any questions or comments, and also feel free to use the chat as well. As for objectives for this entire course, so number one, really hoping to improve participants' knowledge on limb deformity, chronic osteomyelitis, which we'll be focusing on today, and then next week, primary bone tumor principles. In addition, I think one of our big emphasis is really just using this as a forum and opportunity to foster international discussion regarding orthopedic pediatrics and oncology and management of complications on a global scale. And then finally, just using this as an opportunity to motivate and support the younger generation of orthopedic surgeons practicing in resource-limited settings. You all had the opportunity to meet Dr. Kiran Agarwal-Harding, who's our course chair. And then as I introduce myself, I'm Dr. Abdullah Njai, and I'll be our course moderator. I just want to give a special shout out to our HGOC and SONA global organizing team. This wouldn't have been possible without all of them. And if you go to the next slide, you can see the remaining members of our great team. So thank them for all the behind the scenes work to kind of help pull this together. So as for our case presenters, so our first one, Dr. Malik Jallo from Burkina Faso, and then Dr. Yohannes Shugi Tifo from Ethiopia. We also have Dr. Tangai Chisamatanga from Zimbabwe, and then Dr. Mapor Aru from South Sudan as well. So we're looking forward to hearing their incredible case presentation that they'll be sharing with us. In addition, we also have incredible faculty who will be providing their insight as we go through each case. So Dr. Tangai Chisamatanga as well, Dr. Saad Ilyas, and Dr. Walid Mekki. And then also Dr. Amanda McCoy, Dr. Michael Segbefia, and then Dr. Ramiz Kudzi as well. So as for our agenda, so we'll be going kind of similar to the standard format we've been using. This is kind of our welcome and introduction. We'll head into our first case presentation by Dr. Malik Jallo. After that, we'll have our case discussion. And then we'll hop straight into our second case presentation by Dr. Johannes Tufi. Then we'll go into another case discussion, and then we'll head in with Dr. Tongai Chisamatanga, another case discussion, and then time allowing, and I'm really going to make sure we allot time for this. Dr. Mapur has some incredible cases as well. And then finally, we'll close with our closing thoughts, and then have our closing surveys as well that we'll have you all complete. So we can go ahead and get started. So Malik, if you don't mind going ahead and sharing your slides, we'll let you go with the first case.
Thank you, Abdullahi. I will share my slides. Is it okay?
Yep, that looks great.
Okay, thank you. Good morning, everybody. Good morning, all the audience, all the faculty. And I would like to thank Harvard Global Orthopaedics Collaborative and SONA Global who invite me to share my cases on this Ortho-Pediatrics and Oncology conference. My name is Malik Diallo. I'm from Burkina Faso. It's somewhere in the middle, in the western part of Africa. My hospital is a university hospital in Bobo Dioulasso. It's 400 kilometers southwest from the capital city. And I'd like to share one case that highlight the difficulties or the problems of early management of bone infection. This is the case of Mr. let's say B.I., born in 1986. His family come from the poor background. He sustained a pain one day after school and a football game. He was 11 years old on that time. He started to complain left hip, left femur, and right hip pain in the fever. The parents start with traditional bone setters. Then they bring the child to the hospital. They weren't satisfied with the hospital care, so they left the hospital without medical advice. So they try again to go back to the traditional bone setters. He says it was very complicated for him on that time. He still remember today how hard it was for him. He was unable to move, lying on the bed. So he had to crawl like a baby and then to the chair and before starting to work with a stick. This started in 1997. He came back in the hospital 5 years later. And he was one of my children then wanted to check him, but they weren't able to pay for the hospital. So they left and they go back to the traditional bone setters. This is the first X-ray they made in 2002. And we see him in 2008. And on that time, he got support for surgery. So he came with 2 hips and the left femur chronic infection. And the third surgery was did on that time. A large abscess on his left side was debrided. And the year after that, in 2009, things got worse. And especially in the left side was very swollen pain. And then they did a second surgery, but no pathogen was identified. Till in 2011, he's still complaining of intermittent pain. He has a sinus tract drainage every 2 months. And but he started to do nursing studies, but was uncomfortable in some places, and he wasn't very fast in doing some tasks. The first time I see him was in 2015. It was things were getting quite stable. X-ray was stationary, And on that time, he started to work with as nurse, but mainly administrative tasks. This is the X-ray from 2011. As you see, the left femur was very, we have very hard bone with stigmat of chronic infection. And 2 years later, he came back to me with pain and important drainage on the left hip, on the left thigh, and the hip was very pain. He wasn't able to walk more than 5 minutes without a pain. So we planned to go for the surgery, and we needed to get support for that. So it took us more than, I think, 11 months to get that support. And finally, I did the surgery the year later, in September 2018. And the surgery was very difficult. The bone was very hard, and I had to remove a large window to get access to the secostrom. I wanted to ream the femur, but it wasn't possible. I failed to do that. As you see, I tried with in the upper part of the greater trochanter, but I wasn't able to ream the femur. But I did my maximum to remove a lot of secostrom. And the surgery helped a lot because after that, he didn't complain pain on the thigh, and there is no sinus recurrence. He got married on that time, and he got children in that time. So things was getting better for him. But I see him years later. He's still complaining some pain, but we were planning to do hip replacement, but I wasn't very optimistic to do that before, because of even we get support because of the infection history. I wasn't very how can I say, very motivated to put to do hip arthroplasty to him. I see him last week. He can walk. He's just walking, still working as a nurse. He has no sinus, but you see, he's leaning side and side. This is the way he's working. No sinus track. He has some joint limitation. As you see, he can bend the knee. This is the right side, and he will bend the left side. As you can see, he can bend, but the right side has more limitation than the left side, and he can't squat. You see, it's the maximum of hip flexion. He can't, but he has family issues. He wasn't able to get more than one job. It's he wasn't able to make more money, so he get marital problem with his wife, and get divorced. And this is how his things are. This video was taken yesterday. So these cases highlight some features about epidemiology. You see it's mainly around 11 years old. And sometimes we have people with precarious immunity, sometimes malnutrition, sickle cell disease, chronic anemia, and usually things we get not more than one site, multifocal, and usually lower limb infections. And for the pathogen, the study we did is highlighting the Staphylococcus aureus as the main pathogen in these cases, but we have a lot of limitation because a lot of exam we do show no result. Why it's this case? Because sometimes we are not able to do correct hemoculture, correct sampling, correct conditioning, and correct cultures to see the right pathogen, to see it very right. And sometimes we use antibiotics with being blind using antibiotics without knowing which pathogen is involved. And we have also a lot of management challenge. Is the involvement of traditional bone setters. And this is mainly due to poverty and belief in the, and sometimes they also can speak well to the patient. I think in modern medicine, we have some issues with to make our patient understand what we can do for them. And maybe with health insurance, it can help to reduce the impact of traditional bone setters. And the second problem is also the fever problem. In small hospital, they always treated fever like malaria. Sometimes a child can come with bone infection and they go for malaria. So sometimes it's usually missed in small hospitals. And we have also limitation again for medical imaging. As you see, a lot of imaging is only X-rays. It's hard, difficult sometimes, usually due to cost to get CT scans or other type of imaging for our patients. And as you see, it's require a lot of surgeries, and sometimes every surgery is a cost for the family, for the patient, and things can't not. It's require a lot of surgery, so it's sometimes be difficult. And how about joint replacement in this case? I let the discussion open. Maybe some of you can share their thoughts about doing hip replacement in this situation. It can help the patient because he will remove the pain, he will help you move and do a lot of job, but the big problem is joint infection. If you get an infection to the processes, it will be worse than not doing the prosthesis. Other problem is the impact for the society. As we see, it's a long process. It's the family sometimes need to be here to help the patient. And this infection also had issues with work and career problem. This case also highlight how this man wasn't able to do all nurse tasks. He's only limited to one or only administrative task. He can do a lot of things. And also you see it's sometimes difficult if you have to provide to be with your wife or your husband. It sometimes leads to problem if you cannot make a lot of money for your family. And the key for these cases is prevention. I think we have to focus on childhood infection to make early diagnostic and adequate management, not to get things stay for long. There is a saying in French, they say in English is once a bone infection, always a bone infection. We have to break that to make sure our patient will come and have a better life after a bone infection. Thank you.
Awesome, Malik.
Thank you, Malik.
Yeah, that case was incredible. I think you did a really good job of kind of highlighting the multifactorial barriers that you have to consider. So not only initially dealing with the delayed presentation, but also considerations on, are you able to obtain the imaging you want? Are you able to have the antibiotics, or are you even able to obtain the cultures you need to direct your antibiotic treatment? And I think also just looking more at a societal standpoint, looking at the long-term implications, the kind of financial impacts. I think you even highlighted, the detriment this had on his family due to him being unable to get the care he needs. So I think this is an incredible case. I'll hand it off to our case discussants. Dr. Kutsi, I'd like to start with you and kind of hear your initial thoughts on this case.
As we go through the case discussion, Malik, do you mind pulling up the X-ray of maybe the last X-ray that you had of the patient, just so we can have it on the screen for the purpose of discussion?
Let me check. This is the.
Sorry, Ramiz, didn't mean to interrupt you. Just want to have this up so that we can have it for the discussion.
I agree. I think
Okay,
that's a good slide. You had the one right before slide, and that's fine as well. Before after your surgery. So yeah, thanks everyone for joining today. I'm Ramiz Kutsi here in the United States, and Malik for presenting, a very longitudinal case, which is often hard to find. The first thing I commend you for is just having such a long history with images back to years, which I assume this patient was infected, well before either of us was even practicing orthopedics. So the other thing that I appreciate is that video you took. I think it adds a lot of value to be able to get that and to show, despite everything going on, honestly, he's mobile, ambulatory, single leg stance with relatively good motion, despite the surgeries he's undergone. My thoughts on the case. First question for you, Malik, is simply, do you know the extent or the details of the surgeries that may have been performed before you were involved? It sounds like a few years ago, there were some surgeries when he first transferred over from the bone setter. To what extent was there a debridement? Was it just a release of abscess? Because from the x-rays, it seems like maybe the bone itself I guess I can't tell how much bone debridement there was at that time.
Thank you, Ramesh. I think they don't touch the bone, I think they just did some abscess. They just removed the abscess. It's maybe why things things still going on and on, because they didn't touch the bone, just remove the abscess.
It seems very common to me.
And I can understand, to be honest, if you're in a setting where maybe if there is an orthopedic surgeon, if someone can at least start as a child when the patient's younger with, like, at minimum draining the abscess, we would all agree that's not sufficient, but at least it's something. So, sometimes I don't think we give credit to those who are at least trying. But in the setting of an orthopedic surgeon treating this, hopefully we can all take away that, as you did, a very extensive debridement is what would be needed to try to fix this. So then my next question for you is, if you can talk a little about what are some of the challenges to getting cultures currently in your hospital, in your environment. Is it a lab issue? Is it a cost issue? And were you able to get cultures from your procedure to be able to put them on suppressive antibiotics? Because that may lead towards a discussion with other discussants on whether or not to do a hip replacement.
Thank you. We have a lab, but usually we did septic cases after regular surgery, sometimes in the evening or in the night. But the problem is, in the night, you don't get the lab guys. So you have to find a way to keep the sampling before the morning. And sometimes it's the family. I just found one day, one of my patients, it's not a nurse that bringing the sampling from the OR to the lab. It's usually the family. So they have to go to pay and they have to bring the sample to the lab. So sometimes some used to open it, some used to throw it. It's a big issue on that part. In the lab side also, sometimes they don't get all the antibiotics disc. They usually test the disc they got. So sometimes you can get if they have only 10 antibiotics, they'll just test the 10. You won't be able to find if there is another antibiotics that can be more effective on your pathogen.
This seems like a big Malik, I'm sorry
how the things ways.
We've talked about this before, Malik, that the challenges of getting a good culture and the sensitivities, the antibiotic sensitivities are really a problem in many parts of the world. I mean, when you send this, intraoperative biopsy sample to the lab and you get the results back, how confident are you in the results that you get, and do they actually end up guiding your treatment?
Yes, but we find a way to go around that. We made a lot of samplings, and we used to send, sometimes if the patient can, we send outside the hospital to the private labs. So we have one in the hospital and one outside, or maybe two outside if the patient can afford that. So we can get a larger view of that. So we can be sure if you have some pathogen, the same pathogen outside and inside the hospital, you can be sure this is the right pathogen to focus on.
The other thing I thought was very interesting about your presentation is you brought up the issues of antibiotics. I mean, you know, in many hospitals that I've visited, you will have ceftriaxone and maybe metronidazole, but the availability of antibiotics, not to mention the lack of data on the culture sensitivities, means I think that we end up giving ceftriaxone constantly, thinking that it's going to do something, but perhaps we're creating multi-drug resistant bacteria. And many of these patients may be infected with resistant strains. So just wanted to get your thoughts on that. And then also thoughts from many of the other speakers on the challenges that they've experienced with that.
Yes, it's true. We have a lot of issues with ceftriaxone. I think in the whole country, it's not only in the infectious, the bone infections. I think they did ceftriaxone for a lot of things. So it's a very, I have colleagues and working on that on that issues, and they did a big. I have, maybe I will share some of their contact. They made some research to highlight that and to show alternatives to. But the true thing is ceftriaxone is affordable, and you can get that everywhere. This is the true thing also about, because if you have you want imipenem or some kind of some other type of antibiotics, it will be very expensive and hard to find. And sometimes if the patient cannot pay for 10 days treatment, we choose not to start.
Yeah, very challenging. I think we have our colleague Walid Maki on the line, who's from Sudan. Walid, are you there? Would you have treated this any differently? Maybe if Walid is not there. Tongai, are you there? Oh, Walid, you're there. Go ahead, Walid. You're on mute, I think.
Yeah, this is Tongai. Yeah, I think the challenges are the same because by the time you see these patients, they've probably been given a lot of antibiotics. And the other challenge that you then find is, even if your institution is funded by donors, you will not be able to afford the laboratory charges if you're going private. The ones run by government will probably not have the capacity to do the kind of sampling and give you the results that you want. And even if they are able to, probably the range that they test is going to be very limited. And at the end of the day, you then find it's just an added cost which doesn't add any clinical value to your management.
Yeah, and I mean, this is a disease of poverty in many cases, right? I mean, these are patients who took a long time to arrive to the hospital. It's a socially stigmatizing illness that affects the entire family and the ability to earn money for the caregivers and guardians of these patients. It lasts a long time and can affect function and employability. And then on top of all that, they have a condition that may require multiple surgeries, multiple lab costs, multiple antibiotics that are not first line. So it's a huge challenge for those who don't have the financial resources. And I wonder if there are any examples of organizations or countries who've been able to tackle this in an effective way. Yeah, Walid, you got your hand up. Please go ahead.
I think you're on mute.
Walid, the sound is very poor coming from you. I'm gonna go ahead and mute you because it's just static coming from your side. Sorry about that, Walid. But I guess maybe a key learning point here is that catching these cases early and preventing them from progressing to this level is really, really key. And so for any of the trainees on the line or general orthopedic surgeons, in this case, I would consider myself one, certainly not an expert in pediatrics. You know, the lesson I'm learning here is if you see a case of chronic osteomyelitis, first of all, have the clinical suspicion that an abscess is not just a soft tissue abscess, it may be coming from the bone, and bony debridement is necessary to eradicate infection. And getting these cases early before they become multifocal and become so draining for the patient financially, you know, and clinically, is really, really key. Well, excellent case, Malik. Thank you so much. Just for the interest of time, why don't we move on to the next case? Johannes, are you able to present your case? Yeah, Malik, did you want to say a few words to just wrap up as we move over to Johannes's case?
So it's good. I think I'm very pleased to share my cases, and I hope I can see more cases and discuss with all your team. But we didn't discuss about the joint replacement problem.
Yeah. I was
Yeah,
about to
that's
jump
right.
in and ask
How
if
do you think
anyone,
about
just maybe
that?
almost a quick poll in a sense, you know, who would, I wonder if this may work, but who would proceed with hip replacement on the right side? I'm personally interested in Dr. Tongai's opinion, who I'm sure has much more experience in this on the older side than I do. I would be very hesitant, and I tend to agree, Malik, with your approach right now. The patient is doing not great, but okay. If he gets a septic hip on the right side, I think that is a disaster.
Yeah,
And
I
I hate
agree
to
with
say
that
it because
sentiment.
we have a tool that, you know, it's tempting because we have a tool that may be helpful. I hate to say it, but I would avoid it until you have culture proven eradication of infection, which is just not going to happen, right?
Yes,
I
true.
would be very reluctant to perform arthroplasty. I mean, you have a lot of potential to make this patient way worse rather than better.
There may be joint salvage approaches that other people, but at, you know, maybe 5-6 years ago there were some approaches before that hip was as arthritic and degenerative as it is now. But at this point, I'm not even sure those are going to add value. All right. Well, thank you again for bringing that up.
Cool. Thanks, everyone. Johannes, are you ready to go next with your presentation? Emily, I think you have the slides ready.
Thank you, Abdullah. So, thank you all of you. I'm Dr. Johannes from Ethiopia, and I'm working at Jimma University Medical Center, which is located in southwest part of Ethiopia, of capital, which is around 350 kilometers from the capital, and we are serving for more than 20 million people in this catchment area. So I'm excited to share my experience with this challenging case involving 13-year-old male patient diagnosed with tibial osteomyelitis. So as you all know, osteomyelitis is a complex condition that can significantly affect patient quality of life and requires comprehensive care. So it's very common in our setup, and so I will walk you through the patient background, diagnostic workup, and the operation we did. So this is a 13-year-old boy presented with exposed tibial bone and discharge of 4 months duration, and he sustained falling down accident from 2-meter height tree, and they took him to traditional bone theater, and they applied tight bamboo stick. And on physical examination, there was a sinus tract with discharge over the right leg on proximal anteromedial region with exposed sequestered the whole tibia and distally over the medial malleolar aspect. So we investigated with X-ray, and laboratory parameters were elevated, like WBC was 14K, ASR was under 60, and the CRP is greater than 200. So the reason for the delay for this child is from poor family, and there is a limitation of orthopedic services there, and there is lack of awareness. And the other thing is cost of transportation, and they can get easily this traditional bone setter around. So this is the clinical image on presentation. So he came with this exposed bone after 4 months. So we don't know whether there was initially a fracture or not. So he came to us with this leg with exposed bone. So this is his X-ray, and which shows sequestered almost proximal 2/3 of the tibia is involved. So the fibula is intact. So we took this patient to the OR, and we planned to do staged procedure. So this was our first operation. So we did sequestrectomy, and we debride, and we tried to remove all the sequester and send sample for biopsy as well as culture and sensitivity. So the culture came with Staph aureus and sensitive for vancomycin, and we put him on high dose vancomycin and daily wound care, and the inflammatory markers normalized after 10 days, and the second intervention was done after 1 month. So on second intervention, we took this patient to the OR again, and we did anterolateral approach, and so we marked just our level of fibular cut, both proximally and distally, and we preserved the muscle attachment in between. So we just pushed gently towards the center with our finger, and hold it with 3/5 cortical screw. We used 2 screws distally and 1 screw proximally, and we left the X-fix for the stability purpose. So post-operatively, you was on the wound care, and this was the intra-op image. This was our approach. So we didn't remove the X-fix. So this is intra-op image. So this is intra-op after wound closure. So this is immediately after operation. So the proximal the proximal segment were fractured, but when we see it, it was stable, and we left it. Then he was on wound care, and after 3 weeks, we removed the X-fix, and the wound were clean, and we removed the stitch, and we put him on long leg cast, and we discharged him after 3 weeks. Before the discharge, the knee range of motion was full, and the ankle dorsiflexion can dorsiflex up to 10 degrees, and the plantar flexion 25 degrees. Wound were clean, and the X-fix removed, and the long cast applied, and we saw him after 6 weeks. So this is a X-ray after 6 weeks. So on 6-week follow-up, there is a bridging callus formed, and we make a PTB cast, and start on touchdown weight bearing with 2 axillary crunch. So after 5 months, he came after 5 months, he removed the cast by his own, and he came to us working with 1 crunch, and the wound is healed. There is no discharge. The inflammatory markers were in the normal range. This was his X-ray after 5 months follow-up. So there is adequate bridging callus. So there is a union both proximally and distally. So he is bearing weight. So I have a video. So this is his, yeah. So he came to me like this. He removed the cast by his own and he came walking with one crutch. So the video was recorded after verbal consult taken from his dad. So this is a conclusion. So in developing countries, stabilization of the fibula offers viable solution for children suffering from chronic osteomyelitis. However, aggressive debridement and the infection control should be done first before the major operation. Thank you.
Awesome. Thank you so much for this case. This was great. I guess one question I had, so like, when you're doing these kind of extensive stage procedures, one thing that you will need is extensive follow-up for these patients. So I just want to see how you've been able to kind of maintain follow-up, or if that's been an issue for you when it comes to kind of managing these chronic osteomyelitis cases.
Yeah, it's also our problem, though they are poor, they don't have money to pay for the transportation. So even it's difficult to get them with phone call. So we pay them to come, and we were begging them like to come for the follow-up. So it's one of the difficulties to get the patient for follow-up.
Awesome. Thank you for that. And then Waleed, I know you're working on your audio. I just wanted to see if you'd be available to give some comments as well.
Can I ask you a question, Johannes? How did you manage the dead space after you resected the sequestrum? Did you put any antibiotic cement or beads or anything like that?
So we didn't put any spacer. So we just remove the sequester and the fibrous tissue. So just we did after a month, we transport the fibula. We didn't use any spacer.
Waleed, are you able to
in
speak?
terms of supply to access some antibiotic cement, Johannes?
Yeah, we do.
Because I think sometimes.
Yeah, we do have the cement, but they can't afford for the cement. So all the medication the family should buy.
Waleed, do you want to try to see if your audio is working? We'd love to hear your feedback.
Maybe while he's still sorting out his audio, I used to see quite a number of such cases in Zim, and I think the pediatric population is quite amazing. They do very well once you take out that dead bone, once you take out the focus of infection. I'm not saying you shouldn't use the antibiotic spacers and manage the dead space. But they do much better than in the adults, and
Hello.
I think that's what's forgiving about the pediatric
Hello.
population.
Hello.
Yeah, Waleed, we can hear you. Yeah, thank you, Tongai. That was a great comment. Waleed, we can hear you now. Go ahead.
Yes, I think these very good cases presented by Dr. Malik and Johannes. For the first case, I think there is now, we are working in the middle and low income countries, and we don't need like expensive solutions. We can just use bone cement with intramedullary nailing. We coat the nail with a bone cement, and we ream the canal and we insert the nail. I actually have a series of cases on the femur. One of the patients, I remember, was having multiple sinuses for 4 years, discharging from the femur. And I reamed him. I put him vancomycin and gentamicin bone cement along stout K-wire intramedullary of the femur, and then bone cement from the outside. And for 2 years now, follow-up, he totally stopped draining. There is no infection. Just the bone cement socket is just costing $40. So just always saying that the cost is a burden. Now we can have solutions with just less cost to solve the problem with these patients. Now I'm working extensively into developing these techniques and being available, provided the bone is intact structurally. So we don't create instability or fracture or a defect. And in such case, then it will need reconstruction by bone transport or muscular technique. For just those who's having a structural integrity of the bone, we can do many maneuvers in debridement, but without compromising. We do sequestrectomy, but without compromising the stability of the bone. When the patient starts to wet beard, it shouldn't affect the stability and predispose him to pathological fractures. So bone cement is working very nice. For the Johanna case, I think he did an excellent job, and he really solved the problem, the fibula with the defective bone. We don't in children, we don't need to do bone transport in such cases. The fibula just stabilize later on, and it's great job, yeah. And it doesn't cost much money.
Thank you.
Whoa,
I think there's a question in the comment section where they say, did you consider contralateral fibular transport? Maybe can I just comment on that? Again, like what Dr. Walid is saying, you must consider this is us presenting from the low income or middle income countries where you might find that you probably might not really have techniques, for example, to do a free fibular transfer. You don't have the microscopes, you don't have the expertise. And also, one of the key things that we see, and we are always cognizant of, is the fact that there's always a chance of losing your patient to follow up. And therefore, you don't want a patient who already has their own issues, and then we give them another. So it becomes like a comorbidity if you then attend to the other leg, which has no issues. I mean, it's a good technique on paper, but then I think it's something that might cause problems in terms of follow-up and in the event that they also then start having issues with that particular leg. I don't know what others think.
No, I think it's a good point. I mean, obviously, donor site morbidity, Tongai, is a real problem that we should certainly consider anytime we're offering a free fibula to any patient. I think, taking the contralateral fibula, doing a free fibula, I would absolutely do it vascularized, because this is an infection case, and having blood flow, delivery of antibiotics, to the bone is essential. Putting a big chunk of dead, autograft in there, if it's non-vascularized, I would be very worried about it becoming infected. In this case, like you're obviously what Johannes has done is essentially just maintained the blood supply of the fibula, and that's why I think it worked so well. And I think one of the comments made is that the periosteum was also your friend here. You had that sort of cross bridging between the fibula and the tibia. But Tonga, I think you bring up very important points about why going to the contralateral side may have been the wrong decision here. Despite the fact that, one question I had for you, Johannes, and for you as well, Tongai, is, does the fibula hypertrophy to allow the patient to bear weight, and how long does that process take? Do you find that patients end up being able to put full weight on this? Walid's shaking his head no. Walid, did you have a comment on that?
Yes, I think it will stabilize very well in children. And usually we don't need the vascularized. Just if you push it with a little bit of muscular attachment, that the pediatrics have a thick periosteum with good blood supply. And with those feeders coming from the muscles, you will get a very nice healing integration, provided you fix it like Johannes did, with the screws in the proximal part and this part of the tibia. And the tibia is very, very nice. Actually, I did one case one week before. And if you follow just for like 2 years, you will find almost the fibula is almost equal the thickness of the tibia. But in adults, that's another story. In adults, it's preferably to be done by a vascularized graft.
Great, thank you.
Dr. Walid, you're saying this is for a free fibula from the contralateral side?
No, from the same side I did.
Okay, no,
I do not recommend taking from the from the contralateral side, unless you don't have fibula at all. For example, if the patient had infection and someone before you did remove the whole fibula and you don't, then you can take from. But I'm always conservative taking grafts from other sides. I prefer from the same leg. Yeah.
Can I come in?
Yes.
Yeah, please, Mapur.
Yes, I agree with the explanation that was given. For example, the first case was a case of very sclerotic osteomyelitis. I think the way it was supposed to be tackled was debridement plus antibiotic impregnated rod through the medullary canal, and that would have actually helped. Concerning the hip, of course, you have to work out the parameters of infection. You don't need to put a hip replacement, for example, in infection. To this case of our friend from Ethiopia is a very nice case. And we are almost doing the similar cases like what he has done. Before you remove sequestrum, there's imblocrum already there that try to push the sequestrum out because sequestrum is already a dead bone and the body try to heal and get rid of infection. So there is imblocrum that is growing. So if you can see where he put the fibula, there is a very nice imblocrum posteriorly, and that imblocrum will combine with the fibula and it will form a better bones later on if you follow it up. I have 2 cases of similar condition, and they are doing well now. Thank you.
Thanks, Mapur. Yeah, actually, there's a question that was raised by one of our participants about leaving. The question is, have you considered the presence of involucrum before you remove the sequestrum? And I've actually had this conversation, I believe, with Malik about, when a patient comes in with a sequestrum, you allow the involucrum to mature so that there's structural integrity to the bone before you remove the sequestrum. And that helps with the healing process and allows for earlier functional recovery, I suppose. But in this case, the bone is extruded, right? The bone is coming out through the skin, it's exposed. I think that it's pushing your hand to intervene soon without allowing involucrum to mature. Is that fair to say?
Sure, and that's true. If you don't have any active fast discharge, and you see there is a sinus which is discharging minimally, you can actually buy time inside that. You have a proper imbilocrum, and then later on you can come and remove the sequestrums. Sometimes this sequestrum, you can then pull them out from the outpatient sometime because there are cases that comes very exposed, sequestrum is almost falling off. So what you do, you just pull it out, irrigate it, and put a back slab until you have a very established imbilocrum later on, and then you come and do debridement and close it up. So kids are very wonderful compared to adults. Thank you.
There are a couple more questions coming from the chat, which I think are good. First of all, Dr. Warren Terry is asking if we could just pull up the last X-ray to see the healing. Giannis, do you mind going to that last X-ray? And I think from that last X-ray, there was a point made by one of the commenters. I can't find it now, but it was about the proximal site. The proximal site looked like it potentially could benefit from additional bone graft. I mean, I know that you have this wonderful periosteal reaction coming from the proximal fibula, which is also bridging. But were you concerned at all? Did you consider adding additional bone graft at that docking site?
Yeah, just for now, I just want to follow him. There is a good breathing callus formed here. So later on, I will follow him at least for 7-8 months. Then I will consider grafting him after, if there is no any breathing callus here.
Yeah. And then the other very important question here is about the soft tissue coverage. So the patient came with this exposed bone, you performed the debridement. How did you manage the soft tissues initially? And how did you, it looks like you were able to achieve primary closure here. Did you do any sort of flap to cover it at all?
No.
Or were you just, please go ahead, tell us what you did and how you thought about it.
No, we didn't use any flap. So the bone was piercing with when we remove the bone, there is a dead space. We just approximated primarily, then it heals, and he was on daily wound care. We didn't use any flap. We just closed primarily after debridement.
And I suppose with removal of all that infected tibia, the volume inside the leg was smaller, so perhaps the soft tissue coverage wasn't quite so challenging. But is that, do you find this to be a problem when you also have these big soft tissue defects? Like, do you have plastic surgery colleagues available? Do you use any adjunctive treatments?
Yeah, we do have a plastic unit here. So, and we are doing that for some cases.
Yeah. Mapur, how about your situation in South Sudan? What would you guys do if you had a soft tissue defect that you're struggling to close? What would be the techniques you would take?
Yes, thank you. Actually, the issue of plastic surgeon is an issue in this world. But as orthopedic surgeon and as somebody who has been in training, there are common type of flaps you can do, like gastro, soleus, reverse sural. But in most cases of children, they don't need these fancy difficult flaps, but you can do cross leg flap in cases that need fasciocutaneous. You can do advancement flap. So these are flaps we can do as orthopedic surgeon, but anything to do with vascularized or anything that need a plastic surgery, that's what we cannot do. But most of the common flaps, we do them. Thank you.
Excellent case, and thank you for a great discussion. For the interest of time, I think, Abdullah, if you agree, we should move on to the next one.
Yeah.
If any faculty want to make any final comments, please feel free.
Just while you pull up the
Dr.
slides,
Warren,
one thing we haven't. Oh, sorry. Go ahead.
No, please go ahead, Ramiz.
I was just saying, while we pull up those next slides, hopefully in the next two cases, we can also focus on one point about potential growth arrest. So in that last case, 13 years old, I appreciate that Dr. Johannes is following this patient, because you still have an opportunity to do growth modulation on the other side if this tibia is shutting down in terms of the physes. So as we talk about osteomyelitis in children, continue to sort of keep that in mind on what can be done before they reach adulthood to prevent the bigger surgeries later.
Awesome, cool.
We have a couple of comments here in the chat from Dr. Warren Terry. I just invite Dr. Terry, if you'd like to unmute and share some thoughts with us, we'd be very grateful.
I think.
Oh, you're muted, I think.
Mute. Okay, yes, no, I think it's a great case. I think you've done a great job there. It looks like overall alignment is good. I have, I think it looks like you've gotten that sequestrum well, and you've had good soft tissue coverage. I always get a bit concerned about pulling the flaps that tight at the first case, and I would be, fairly quick to do a rotation, just a fasciocutaneous rotation that's easy to do. And I'm a bit concerned looking at the proximal and distal tibial physes there, but I think it's a well done. If I came out of it at the 3-month point looking like that, I'd be pretty happy. That periosteum looks like it's got, you've got extra support of that proximal. The kind of, it doesn't look like there's still some question about union there, but you've got that bridging, that proximal fibula, which is supporting that. So, I think overall this kid should probably do well. I'd consider that a real success.
Yeah, excellent case. Thank you for those comments. But yeah, the issue with the physis is very important. You know, thanks for bringing that up, Ramiz. Tongai, if you're able, we would love to have you present your case next. If you have your slides, are you able to present from your screen?
I think should be Emily is going to. All right, cool. All right.
Great.
Yeah. So my name is Dr. Tongai. This is a case that I saw while I was working back home in Zimbabwe. I've since moved. But it just highlights the same kind of challenges that we meet in our low income and middle income countries. And yeah, so this was of a 13-year-old girl. So she had been having draining sinuses for more than 5 years. She had been walking with bones sticking out, I think, for the 2 years prior to us seeing her, with also swelling around the leg. And one of the things that touched me about this case is I think the 2 years prior to being seen by us, she had stopped going to school, because, you know, these are things that sometimes we don't look at. So it's a girl who had just become a teenager and becoming quite sensitive about themselves, and walking around with dead bones sticking out is probably not the best of things to happen to you. And I remember when she walked in, there was, you know, like a smell that you could smell as she walked into the door. And you can imagine the community, you can imagine other people that are around her, how she probably became isolated because of that. Next slide. So of course, I mean, the question will always be, why didn't she come early? So we've got big challenges where sometimes our government institutions are so overburdened with trauma. And for example, if you have trauma in someone that's still economically active, say maybe a 27-year-old was going to work and then involved in a road traffic accident, that's someone that might actually get priority over, you know, someone who comes in complaining of pain in their leg, a bit of temperature, maybe prior to that, the throat pain. People tend to sometimes take x-rays and they say, okay, there's no fracture when they are being seen at the lower end health facilities. And then they go and then eventually develop chronic osteomyelitis. So yes, I think the emphasis that we're trying to get out of this is to say, okay, look, we must have a high index of suspicion, but at times you've got other things that are competing with this particular patient, to say, even if the doctor thinks, oh, this could be it, they are not probably going to get there at a time. They are going to have issues taking that patient for the management that they'll be thinking is correct at that time. So sometimes they get into that chronic stage because of the system. So I just wanted us to, back to the previous slide. I think these are principles that we all know when it comes to, say, bone infection, and in this case, chronic osteomyelitis, that we must, for example, do a thorough debridement. During that debridement, that's where you get the samples, send them to the lab, and you end up with having a goal-directed antibiotic therapy. There's an issue of managing the dead space, because sometimes if you don't do that, you end up having that as a nidus for infection, and your thing can really repropagate. There's an issue of soft tissue cover and then stabilization of the bone. And if you look at the cases that have been presented so far, including my case that I'm presenting, those are the things that will be hovering around to try and meet. Some you meet them much easier than the other. Some you might, some you need maybe other people to be involved. But when you are in such setups as ours, you probably need to be able to do all 5 and make sure that you give the best of treatment to the patient. Next slide. So this is just intra-op images. So we used a C-arm to just try and make sure that we get rid of all the dead bone. So I think the correct term to use when you're dealing with chronic osteomyelitis is not necessarily to say, okay, we are removing sequestrum, but it's basically just say you are, okay, the debridement and just getting rid of, all the dead bone. Because sometimes I would see it even during our training back home that people would talk of sequestrectomy, and sometimes just means going and taking out the dead bone and that's it. But you actually take out the dead bone, do a proper debridement, make sure that anything that's dead, because the small piece of dead bone that you leave is the one sometimes that propagates continued infection, continued sinus formation. Next slide. So this is again intra-op. So we had taken out the dead bone and then went on to debride. So you see on the slide on the left, but then you see you are left with a gap, and that gap in the soft tissues, or that big hole, is over a portion of the tibia, which is quite superficial. And if you look at that particular shape of the hole that you have there, it's not probably something that you can just do primary closure in terms of just trying to put sutures across. So one of the key things that we have, I think, over the years, and I think this is one thing that I want to highlight from my presentation, that we've had partners that have come in to assist us. There's a yearly course in which is done in Dar es Salaam in Tanzania, where we have faculty from one of the American universities through the SIGN program. SIGN program is there's what's called the SIGNL, for those that don't know. It's one of the things that has really revolutionized trauma care in Africa, where you've got an intramedullary nail where you don't need to use C-arm, for example, to be able to do the surgery. So they've also partnered with some organizations that have now come in to also deliver some of these skills, like plastic surgery skills, to orthopedic surgeons. And this is also where I learned some of the skills that I'm presenting with this particular case. So this is what's called a keystone flap. So at least it allowed us to have closure of that wound without much tension. And I think it really, really helped, because next slide. When we made follow-up to the patient, so this is about a year down the line, no more sinuses. Yes, there is a scar, but the patient was able to go back to school. I mean, when they came in, they were mobilizing full weight bearing, because I think, like what was mentioned earlier on, sometimes when you see these patients that have been like this for a long time, you find the involucrum can form quite structural bone, and this allows you to be able to manage them in terms of weight bearing much better. The challenge that we meet, and I'm sure my other presenters will attest to, is the dead space management. I would say, for example, back home in Zimbabwe, you're looking at bone cement costing maybe around 250 US dollars. And even
What?
Yeah, about 250 US dollars.
Just 60 here. Okay.
Yeah, and if I were to try and import it from your country, it just comes to the same amount, because you are charged duty and other things. And therefore, even in the setup where I was, we were able to treat the children for free. And this is also what the GIST helped. But you find then, if you then put in a 250 on top of, because there's nothing called free. Someone is assisting you to be able to do these things. And sometimes we are not then able to do to the extent that you should. And also you consider in terms of follow-up, yes, say if you do the muscular technique, are they able to then come back for follow-up? Sometimes they might not be able to, because the time when you want them to come for follow-up, that's the time when the family is supposed to be tilling their fields. They are supposed to be planting corn and all those things. So some of those factors might lead to them defaulting your treatment. So you try and do things that allow you to minimize the visits, but at the same time try and deliver quality. Yeah, so next slide. So these are some of the things that sometimes as clinicians we might not consider, but they are social complications. I'm not going to talk about, the medical ones. The social ones are also very important because that is what makes up your patient. I did highlight that this child was isolated, really affected her self-esteem, and she was also going into depression. I know it's a bit strange to say depression in kids, but it does happen. And she did attest to the fact that she was also going into depression. And there's also always a heavy financial burden on families, traveling. And even if you're going to bond setters, there's money that's needed there. So there's a lot of things that go. So I think in summary, this is just a case that I wanted us to add on to what others have presented on, some of the challenges that we meet, but then what some of the skills that we've gained over the few years can help to try and minimize, the visits and try and make sure that maybe we get to some level of giving the patient back their life. Thank you.
That was awesome.
Thank you. Superb, yeah. Superb presentation.
It sounds like a couple of questions in the chat are kind of regarding your the flap covers that you use. Could you talk a little more detail about the Keystone flap and kind of considerations you thought in terms of using that versus other types of flap coverage?
Okay, yeah. So this was also in consultation with some plastic surgeons. I think the options could have been, I could have probably, seeing where the wound is, you could have used a gastroc, maybe medial gastroc flap, and then you put in a skin graft. But then with this one, the Keystone flap, you look at the, you could say the diameter of your defect, yeah. And then what you then raise in terms of, if you look at the other side of, or the bottom part of the flap, it to be maybe close to about 1.5 times that diameter. And then what you do is, with most of the areas of the skin, of course, you know that they're the perforators, isn't it? So you try, as you are raising your flap, to leave some of the main perforators around that area, and it's just transpositioning it. And then you just transposition it. So you are raising around that flap so that you can then transposition it. And then you go to where the defect is. That's where you first suture, and then the other areas you then suture after.
It's really great.
Yeah.
Please, Walid.
So it was.
For how long have you been able to follow up this patient? And what was her laboratory parameters like CRP on last visits?
No. So even on the first visit, this is someone that had this challenge for about 5 years. So they were not, medically, they were not ill. CRP was less than 20.
Okay.
ESR, I think, was about 50. She was not pyrexia. So this was someone who was okay if you look at it in the medical sense.
So she was not having like an acute on chronic exacerbation.
no, she wasn't having an acute on chronic. She was just walking around with dead bones sticking out. She was just having the sinuses that had been draining for some time.
Yeah, yeah. In such case, yeah, the inflammatory markers will be dropped down. Yeah.
Yeah. So, and then the other thing that I need to also highlight is I don't know about the other countries, but our laboratory support was very, very poor because you find when it came to, if you took bone samples, like we took bone samples, I used to do it like the early days when I started working at Cure, take bone samples and then you send them to the lab. And they couldn't come up with anything. They only when maybe you sent in, like, you know, the swab, the one that the pus swab or wound swab, maybe that they will say, okay, this has grown, but that's not representative of what's going on.
Yes.
I want stuff on the bone. So it took a long time to get them to that level. And then ideally, when you go in and do this kind of surgery, you want to send in about 5 samples for micro. You want to send in about 2 samples for histology. And so at the end of the day, the thing is, the laboratory, in the ones that would be dealing with would be private, and they want to charge you per sample. So you end up, it's as if you have sent samples for 7 patients. And therefore it wasn't economic. Even on our situation where we were treating the patients for free, but I couldn't then burden the system to a point where you then, because everything was done according to budget. So I couldn't sometimes then take samples for 2 patients and then the whole budget for the year is gone.
Yeah, these were
So
some
can
of the
I-
same issues that we were bringing up in Malik's case presentation. The financial challenges are huge for these patients. There was
Yeah,
a question
I
in
wanted-
the chat. Oh, sorry. Go ahead, Ramiz. Sorry about
Well, I
that.
just wanted to follow up with Dr. Tonga on that point. It's come up a few times now, the cost of the samples. So what strategies have you taken then? If you're unable to get adequate sample for cultures, are you just empirically treating with certain antibiotics that you feel are most likely, or are you just sending, fewer samples? In this case, how did you decide antibiotics?
So in this particular case, we ended up just working on the maybe just the one sample, and then looking at clinically what we had in terms of the patient. Because the other thing that we also considered was, this is a patient that had been on numerous antibiotics over the 5 years, right? And we didn't know in terms of the resistance. We didn't know in terms of what works. And I think our key thing was the things that we were in control of were like the surgery in itself, the extent to which we could go in and clear the infection that we are seeing, right? And also maybe the ability to then say, if something else comes up, right, we can then be able to design our treatment accordingly. So we just went, did a thorough debridement. Then we like I was saying, the inflammatory markers were not it's very significant. The samples that we sent, I think because this patient had been on antibiotics for long, and there was no growth. Yeah. And our pediatric colleagues, I think we just then gave empirical antibiotics for about 2 weeks, and then followed them up. So we were able to follow them up for a year. No sinuses, well in themselves, but of course with the with the instruction that if in the event that these sinuses return, and we documented it on our discharge to say they must not be started on antibiotics, so that we are to go back in, we are going in and probably treating properly. So I think what we avoided was to treat ourselves by just giving antibiotics for the sake of, when in this particular instance, we're not clear of the history. And back home, the issue is it's a big issue where if you get resistance, you're gone, because our options are very, very minimal. So in this particular instance, we had to work with what we were seeing clinically, work with the history that we had, which was very unclear, and then yeah. But I think the way I would do it differently is, I mean, if we had probably, local antibiotics and, things like calcium sulfate, and yes, maybe those would help, and also just limit our need for prolonged oral antibiotics.
Yes, there's a question in the chat about that, about did you use or consider any local antibiotic like Vanc powder? I believe this was just maybe IV and then maybe switch to oral antibiotics.
Yeah, no. So we didn't use anything like Vanc powder.
Yeah, it would be a great area of research for all the people on this session today. Much more research is needed from your experience, maybe looking back at cases and figuring out what is the appropriate duration of antibiotics when every week is such a high burden of cost. Getting out to 6 weeks is not practical in most environments.
Fantastic
Okay, what do
case,
we
Tongai.
consider
Let's
moving to the final session?
Thanks, Ramiz. Exactly. Let's
No.
do that.
Okay.
We'll have more time at the very end to answer a few more questions here and there as well, but I'd love to have a little chance here for Dr. Mapoor to present his case.
Okay.
Awesome. Cool. Yep, you're good to share your screen.
Right.
As we pull up Dr. Mapoor's slides, I just, a lot of the questions in the chat about antibiotics and that sort of thing, I think for me, a teaching point on chronic osteo is that this is a surgical pathology with a surgical treatment, right? Like you have to adequately debride the bone in order to treat the infection. You can't count on local antibiotics or systemic antibiotics or anything like that to eradicate the infection for you. And so for those of us like myself who are not pediatric fellowship trained, and when we're dealing with things like this, I think there's always a fear that we're going to go beyond a point of no return when performing debridements and create real problems for patients. And so we're a little nervous to do what's sometimes necessary, which is an extensive radical debridement that's adequate. And, we've got Dr. Walid on the line here who does, bone transport and fills these defects and all kinds of things. And if you have that kind of skill, I think you can be very brave. It's easy to be more brave, but I think a teaching point that I'm learning here from this case discussion and from all of the speakers is that you really do need to eradicate the infection surgically, not just rely on antibiotics. Anyway, I'll be quiet now, and please, Dr. Mapoor.
Thank you. I'm Dr. Mapoor from South Sudan. I'm going to present some few cases on chronic osteomyelitis. I won't bore you again with this literature. I believe you can read it. But the focus here is actually you need to prevent chronic osteomyelitis or acute osteomyelitis from occurring from the first place. So timely diagnosis and treatment is of importance. Give organism-specific antibiotic, and that's what we all agree on. We have to take sample, send for calcium sensitivity, do thorough debridement, and if need be, you stabilize the bone, and if it is stable, then leave it that way, and then you closely follow up your patients. So the first case I'm going to present is a case of 8 years, male with no history of trauma reported by the family. Patient presented with swelling of the upper part of the left leg. Patient couldn't move because the leg was so painful. So that patient was first taken to a traditional bone setter and was given herbal medications by the traditional bone setter. And later on, the limb start to discharge fast. So patient was taken back again to traditional bone setter, of which he decided to open up the discharge part to extend the wounds. And that's discharge continue for 3 months until the soft tissue become necrotic and fall off and the bone become exposed. So when the patient present to our clinics, he present with this clinical feature. The anterior aspect of the leg has lost all the soft tissue, and you can see the bone is exposed, is completely white. That means it's completely necrotic. And if you could see on the X-ray, AP and lateral view, you can see there is demarcation between the imblocrum that is being formed and the dead tissue and the dead bone that is actually in between. So you can see the difference between imblocrum here and the sequestrums. You can see on the lateral, the exposed part is this area that is exposed and is a bit sclerotic. So this what we have seen in the hospitals. So the treatment here is you go in, do your sequestrectomy, do proper debridement, irrigation, wash out, and now you will be left with how to close the soft tissue defect and how to treat the dead space. So in this case, what we did, sorry, I didn't include the soft tissue treatment in this case. So what we did a closed cross leg flap, where we bring the other leg to take a subcutaneous tissue and fix it to that defect and leave it for at least 2 weeks, and then you removed that limb, and that's area that is the donor side. You do a skin grab on it, and then your recipient side, the subcutaneous tissue, the fasciocutaneous tissue that you took from that side will have already taken by now. So you can see the length of the sequestrum that we have removed, and you can see what is left, the imblocrum that is left. So in this case, I didn't put X-Fix. I didn't put on X-Fix. After doing sequestrectomy and debridement, plus the cross leg flap, I sliced the cross leg flap with an external fixator. But in 2 weeks after I removed the cross leg flap, I removed that external fixator, and I strictly allowed the patient not to bear weight with the help of the pharynx. So I was relying here on the fibula that is intact and strict information to the parent that they should not allow the child to bear weight. And after the graft has taken up in 4 weeks, I brought the patient back, and that's when I put the patient on back slab. So that's the first case. My second case is a 5 years male with history of trauma fall while playing with the siblings. Few days later, the parent reported that there's swelling on the left leg, and patient refused to bear weight. So patient present to the hospital 6 months later with multiple wound discharging fast. On clinical examinations, there was multiple sinuses on the anteromedial part of the leg. There was also shortening of about 1 to 2 centimeters. So on examination, this is what we have seen on the X-ray. There is a bony defect with sclerotic bone in between, and that's And there is also a pathological fracture, if you could see on lateral view here. So that pathological fracture is due to chronic osteomyelitis. On the a photo that we have taken, there is a sinus discharge from the proximal aspect, the medial aspect, and also the distal part of the leg. You can see these are sinuses that are discharging past. After we did sequestrectomy and debridement, we find that the limb is unstable. So we had to put an external fixator for 4 weeks. And then after 4 weeks, we remove external fixator and we put the patient on bed slab after we have seen the wound has healed. Sorry, I don't have a follow-up x-rays, but it's going to come in the next 4 weeks, and we'll be able to do follow-up x-ray. Case number 3 is a 6-year-old male with past discharge from the left upper chest. The report history of trauma, fall from a tree 4 months ago, and it was associated with bleeding, but the parent reported swelling, but there was limitations of the movement of the shoulder. So they couldn't tell that there was a fracture, but they said there was a little bit of bruises which was bleeding, and the child couldn't move the shoulder. So on clinical examination, on presentations, there was exposed middle end of the clavicle with past discharge. On doing x-rays, you can see here there's a bone discharge, which is the clavicular, the middle aspect of the clavicle at the sternoclavicular end is exposed and is discharging fast. And if you could see an x-ray here, the joint here is a little bit disrupted, and you can see the bone, the color of the bone here has changed. That means this was an exposed part of the bone. So what we did, went in, we did surgical debridement, we just pull out that exposed dead bones, and then we curate the base, and we wash it out. And you can see this here, you can see that there is a new bone formation that's in bullocrum in place. So that's why children's, they have these powerful healing potentials. You just need to get rid of the dead bone and irrigate it properly, debride properly, and give them antibiotic based on the culture and sensitivity. Case number 4 is a 5-year-old female, present para-report spontaneous swelling of the thigh with no history of trauma. They took the patient, the child, to traditional bone setter, and the traditional bone setter was treating that child for 3 months. Later, the patient presented to hospital with past discharge from the left side of the thigh. On clinical examinations, the child was malnourished, there was shortening, there was ricobatums, deformity of the distal end of the thigh, and there was multiple sinus discharge. So on doing an x-ray, you can see there's an isolated in the sequestrum with a well built up imblocrum with a little bit of pathological fracture here because the limb is unstable and the child tried to walk on it. That's why you can see there is a little bit of bending here. And you can see here the separation between sequestrum, imblocrum, and because the child is still using that limb. So we went in, we did surgical debridement, we removed the sequestrum. You can see it's a bit long sequestrum, roundish, and you can see there's an imblocrum that is in place. For this case, what you can just do, what we did here, we could put an X-fix to stabilize such that imblocrums continue to calcify and become a strong bone later. So the last case is a 7-year-old male with history of fall while playing with sibling and sustained a closed femur fracture. The child was also treated by a traditional bone setter. What they did was they just open up the swollen part. They claim that the hematoma is a bad blood and it has to be drained. So in spite that they are introducing an infections because they are doing it in a non-sterile environments with tools that are not sterile. So later on, the wound become discharging fast, and the child was unable to bear weight. Clinically, there was fast discharge, brachiobottom deformity, and limb shortening about 3 centimeter. Again, you can see the body itself is trying to fight infection, and that's why you can see the sequestrum is, the body is isolating the sequestrum from the body. And we did surgical debridement. We removed the sequestrums and we stabilized the bones, and the child is doing well now. Thank you so much. And any question?
Thank you, Mapur. Great 5 cases done in a whirlwind, all showing excellent management. And I think a real important teaching point for all of them is the importance of removing the full sequestrum, you know, and the value of that involucrum for maintaining stability of the bone. You also brought up some important points about the traditional bone setters. I think many of the speakers today have talked about the social stigma associated with this, the costs associated with this. I think we've all learned quite a lot. We're a little over time here, but just for the next 5 minutes, I'll open it up to the faculty to make some final comments about the cases that Dr. Mapur presented and any of the other cases.
Yeah, I think, I think the case is presented by Dr. Mapur reflects the problem of late presentation of patients, which is very common in our countries. So just if this patient were picked up early and got the right treatment up from the start, they wouldn't have those complications. So education is very important. I remember I have worked in outstation hospital 10 years ago, and one of the things I did was educating school children. I went to schools and educate them about with the teachers, they together, and then I teach them about how to present early to the hospitals. I showed them some of the complications of traditional bone setters. So I noticed after 2 or 3 years, there is a much decrease in the late presenters and the complications. So this is a complex social and financial problem and beliefs, religious beliefs sometimes, that we need to work on this as a surgeons. So this is very important, and I think with socioeconomic development, we'll not see much complicated cases.
That's a great initiative you've had, Waleed, to go into the community and educate patients themselves. I think that's fantastic. Great example and great leadership. I'd like to ask Malik. Malik, did you have any comments? Since you presented the very first case, you know, I know that you and I have had extensive conversations about the challenges with traditional bone setting, the challenges of orthoplastic service coverage, antibiotics. Did you want to say any final words here?
Did you hear me?
Yep, we can hear you. Oh, not anymore.
There is one question in the chat. Just asking. Awesome. Dr. Mapur, there is one question in the chat kind of asking about your thoughts on length of leaving an X-fix in, especially in children. Have there been any instances where you're leaving it in for longer than 4 weeks, and kind of what goes into your thought process or consideration about like X-fix length?
Yes, so one of the reasons we don't want to leave the extended fixator for long is the same thing: chronic osteomyelitis, infections. Kids are not like adult. They go and play. They can go and fall and cause injury, more injury. the fin side can get dead and everything. So I always try to caution the parents, once these experiments they are for a short period of time, and if you handle the child well, then we will be able to remove the experiments as soon as we could see the bone is getting strong. And also, after I see the wound that I put experiments on is healing well, I remove the experiments and put them on a slab, on a back slab or on a full cast. That's what I usually do. Thank you.
Awesome. Thank you. Just want to open the floor to any final comments from any of our faculty or participants.
Ramiz, any
I just
final
wanted to
comments
thank-
based on the cases?
Yeah, I just wanted to thank all the speakers and case presenters. I mean, this is a great just tour, and each case was a great opportunity to speak about a different issue within chronic osteomyelitis. My personal takeaways are prevention from the beginning, of course, and that's where partnership between orthopedics and pediatricians, I think, is a great move forward, and I appreciate Waleed sharing one initiative he's had. The other is treating early. We all agree in this program today how good the healing potential for children is, and encouraging really extensive debridement the younger the child is to prevent all those problems later in life. So thanks for sharing everyone's cases. I learned a lot.
Yeah, me too.
Yeah, this was great. Emily, if you don't mind, we can pull up our closing slides. Cool. So, I mean, just want to thank you, everyone, again. I think Ramiz highlighted beautifully, but I'm just taking all of you from presenters and faculty and all of our participants from across the globe, taking the time to kind of share your insights, thoughts. I think it really highlights the beauty of having sessions like this where we can bring individuals from across the globe to kind of share their expertise and experiences. So this was great. Just want to put a reminder out there that we do have one more session planned for next week, which will be our oncology portion of the course. So just making sure we'll be sending emails out throughout the week for reminders. So we look forward to seeing you all and hope that you're sharing it with your colleagues as well. We want to have as many people join in as possible. And then just another plug. So we are giving out certificates of participation, but in order to get these, we'll need you all to complete the pre and post-conference surveys. On the right side, you can see the post-conference survey link. So I can give you all a chance to utilize the QR code, and this should be sent out in the flyer as well. And then for those of you who just want to be more involved with SONA Global and the Harvard Global Orthopedic Collaborative, we do have different forums as well that are WhatsApp groups. So ranging from lower extremity trauma, upper extremity trauma, resources for trainees, and kind of more of a forum for policy and advocacy as well. And then also, I think Emily highlighted this last week, but we are working on a complex upper extremity course that will start in November and go through December. So you all can be on the lookout for that as well. So thanks again for joining us. On the bottom of my left and right-hand side, you can see the pre and post-conference surveys. We really would love for you all to fill those out just so we can get your thoughts and feedback as we go forward with making more of these courses. And then Kieran, I want to hand it off to you if you have any last second comments.
No, that was excellent. What a fantastic case discussion, from the very practical clinical side of things all the way to the complex socioeconomic policy side of things as well. I think it just highlights the complexity of this pathology, how urgent it is that we do something at a large scale for treating these very vulnerable patients with a very challenging condition. And I think that if I'm taking anything away from this session, it's the resilience and bravery of surgeons in resource-limited settings to tackle these complex challenges, and the exemplary clinical care put on display by all of our speakers today. I hope serves an example to all of the trainees on the line for what can be done for these patients. And certainly, as Abdullah just mentioned, we are trying our best to create a community of surgeons with experts like the ones that you heard speak today. And we really do hope that we can continue this conversation, all for the benefit of these patients, trying to mobilize resources, awareness, and expertise for their benefit. So thank you all very much for joining today. Abdullah, if you don't mind just leaving this slide up so that people can scan this. We'll also post the WhatsApp link to the global orthopedic community in the chat, as well as the link to the pre and post conference surveys. And we really hope that you'll join us next week for primary bone tumor. We'll be switching a little bit to talking about tumor rather than just pediatrics. But we really do look forward to another lively case discussion, which will close our conference series. And hope to see you for the complex upper limb coming soon. Thank you all.
Thanks, everyone.
Yeah, thank you everyone. Bye.
Thank you very much.
Thank you.
Thank you.